Good morning and welcome to the Virtual Rheumatology Learning Series. I'm Dr. Fotios Kampouris. I'm the Program Director at Yale, and it's my pleasure to introduce you today to Dr. Laura Cappelli. Just a few housekeeping issues. As you see below, the buttons for chat should be used for general comments, which together with Jean Lynn, one of our co-moderators, will help answer. You should use the raise your hand button if you're having difficulty or an issue with the platform or software. And the Q&A really should be used for post questions regarding the lecture content. So I'd like to introduce Dr. Laura Cappelli. Dr. Cappelli is an assistant professor of medicine at the Johns Hopkins University School of Medicine, and where she obtained her MD degree and completed her residency and fellowship training. She also completed her Master's of Health Sciences at the Johns Hopkins Bloomberg School of Public Health. Her primary research focus is on rheumatologic adverse events of cancer immunotherapy, which many of us are encountering over the last 5 years or so. The work involves collaborative endeavors with oncology, laboratory investigators, translational specialists, public health experts across the board. She also co-chairs the immune-related toxicity team at Johns Hopkins. In addition to this, she studies rheumatoid arthritis and is focusing on patients with seronegative disease and on the use of autoantibodies as biomarkers. So without further ado, Dr. Cappelli, thank you for presenting today.
Thank you so much, and it's a pleasure to be here with you virtually, and someday I hope to meet a lot of you in person, but great to be able to talk about this important issue facing rheumatologists, which is immune-related adverse events due to immune checkpoint inhibitors used in cancer therapy. So today I have several objectives that I hope to get through in the next 50 minutes. First, we'll briefly review the mechanism of action of immune checkpoint inhibitors, which is important for understanding why adverse events may occur. Then we'll talk about the clinical spectrum of immune-related adverse events that can occur due to checkpoint inhibitors. We'll talk about their treatments and then compare and contrast them to our traditional autoimmune diseases. And finally, we'll finish up with another clinical conundrum, which is what to do with our patients with preexisting autoimmune disease when they develop cancer and need to be treated with checkpoint inhibitors. These are my disclosures, and pretty much everything used for IRAE treatment is off-label because, as Dr. Kampouris said, these events have really only been recognized in the last 5 years or so. So immune checkpoint inhibitors are only one class of cancer immunotherapy, and they are the most commonly used class currently. These drugs work by blocking negative co-stimulatory molecules, leading to the increased activation of T cells, which hopefully leads to an anti-tumor T cell response. And due to their relatively nonspecific mechanism of action, they have been trialed in many different types of cancers, and they've increased survival in a variety of advanced cancers. Currently, in the United States, there are 7 drugs that are FDA approved that are listed there: ipilimumab, nivolumab, pembrolizumab, atezolizumab, avelumab, durvalumab, and cemiplimumab. And then the combination of ipilimumab and nivolumab is also approved in melanoma and in renal cell carcinoma. So to review the mechanism of action of these drugs, it's important to review how T cells become activated. And T cell activation requires at least 2 signals. So it's not enough for the T cell receptor to recognize peptide bound to MHC for the T cell to be activated. You need a positive co-stimulatory signal, in this case CD28 on the T cell binding to CD80 or 86 on the antigen-presenting cell. And when you have that second signal, the T cell can go on to become activated and respond to this antigen. So like most biological systems, there are built-in regulatory pathways that prevent overactivation of T cells. And the approved immune checkpoint inhibitors target 2 of these pathways. So there is the negative interaction of CTLA-4, which can bind to CD80 or 86 on an antigen-presenting cell to inhibit T cell activation. And then there is the interaction between PD-1 and PD-L1 that occurs more in the periphery and in tissues. And when PD-1 on the T cell binds to PD-L1 or PD-L2, this again gives a negative signal to the T cell, limiting activation and contributing to T cell exhaustion. So the approved immune checkpoint inhibitors target these two pathways. There is one anti-CTLA-4 drug, and there are several drugs that target either PD-1 or PD-L1. But like all of immunology, it's more complicated than simply the effects on the T cells and antigen-presenting cells. So with CTLA-4 blockade, for example, we know that this lowers the threshold for expansion of activated T cells, as we've seen on the previous slides, but it's also important to note that CTLA-4 is trophic for T regulatory cells, and CTLA-4 blockade kills T regulatory cells. And this may be a more important effect not only for tumor response, but particularly for immune-related adverse events. PD-1, PD-L1 blockade also can lead to activation of exhausted T cells, but blocks the inhibitory effects of dendritic cells and NK cells. So there are more effects than strictly at T effector cells that will occur due to immune checkpoint blockade. So this has been a very rapidly growing area, and I used to say that the literature moved faster here than anywhere else, but that's not true anymore with the COVID pandemic that we're facing, where things are moving at lightning speed. But as you can see here from this paper in JAMA Network Open, the percentage of patients who are eligible for immune checkpoint inhibitor therapy has greatly increased. So in 2011, when the first drug, ipilimumab, was approved, only about 1.5% of cancer patients were eligible to receive this treatment, and it's over 43% in 2018 with the increased number of agents approved and the increased number of indications. And those who are estimated to have a positive tumor response has also increased, but not to the same degree. In 2011, it was only 0.14% of patients with cancer who were expected to have a positive response to immune checkpoint inhibitors. And it's up to 12.45 in 2018, but still far lower than the number of people who may be exposed to these drugs. So it's important to note that many of the patients who have complications may not have the positive effects of tumor regression that are desired with these type of drugs. So immune-related adverse events can occur due to immune checkpoint inhibitors, and they can affect almost any organ system in the body. This is a figure from a review that I wrote with the doctors Calabrese at Cleveland, Lenny and Cassie. And in the gray boxes are some IRAEs that we typically don't see as rheumatologists. So there are very common ones like the dermatological IRAEs, pruritus, dermatitis affecting the skin. Some of the endocrine IRAEs are also very common, particularly thyroid disease. There are more rare but potentially life-threatening IRAEs like myocarditis and some of the neurologic syndromes. But in pink, you'll see the IRAEs that are similar to rheumatic disease that we term rheumatic IRAEs, and there's a wide range of them. So it's important to note that most, but not all, autoimmune rheumatic diseases have a similar IRAE. So we see a variety of different types of inflammatory arthritis that can occur due to checkpoint inhibitors. There's Sicca syndrome, which has similarities to Sjogren's syndrome, polymyalgia rheumatica, giant cell arteritis, myositis, vasculitis have all been reported. But when you get to lupus, we have seen cutaneous lupus, but there are not many reports of a syndrome that looks like systemic lupus. There's one case of lupus nephritis, but not really patients that are described as having a lupus-like syndrome their kidneys and serositis and whatnot. So I think it's an interesting point to keep in the back of your mind, and may teach us something about not only immune-related adverse events, but also lupus and why it differs from some of our other rheumatic diseases. but psoriasis, psoriatic arthritis, new onset scleroderma, and many other phenotypes have been described as occurring due to immune checkpoint inhibitor therapy. But it has become clear to those of us who are seeing patients and working in this area that IRAEs are not the same as traditional autoimmune diseases. And we'll go through that in a little bit of detail for several of the rheumatic IRAEs, but here are a few examples from outside of rheumatology. So colitis was one of the earliest IRAEs that oncologists had to deal with because it's fairly common with ipilimumab, the first agent that was approved. And colitis is very different from inflammatory bowel disease. The histopathology differs. There's not some of the chronic changes like crypt distortion that you see in inflammatory bowel disease. And clinically, these patients typically respond very quickly to 1 or 2 doses of infusions of TNF inhibitors, which, as we all know, is not the typical course in inflammatory bowel disease. Another interesting IRAE is hypophysitis, or inflammation of the pituitary gland. So I don't know about all of you, but I still have yet to see a case of hypophysitis not due to immune checkpoint inhibitors in my career. And I think it's not just me, because if you look at the prevalence outside of immune checkpoint inhibitor therapy, it's about 1 in 9 million. This is an exceedingly rare autoimmune disease. But if you look at checkpoint inhibitor therapy trials, hypophysitis can be seen in 1 to 15% of patients, depending on the type of checkpoint inhibitor. So though there are many similarities between IRAEs and traditional autoimmune diseases, there are compelling differences that really suggest that these are not the same diseases and they shouldn't be treated in exactly the same way. So from here, we'll go through a few case examples to introduce some of the common or morbid rheumatic IRAEs that you may see in practice and how we treat them. So the first case is a 48-year-old woman with stage 4 melanoma. She had no prior history of autoimmune disease. She was working as a nurse in a reproductive endocrinology clinic when she was diagnosed with stage 4 melanoma. And she was started on ipilimumab and nivolumab combination therapy. And unfortunately, she developed colitis, but responded well to corticosteroids and improved. And so was continued on nivolumab alone for treatment of her melanoma. Then, unfortunately, she developed hypophysitis, which again was treated with corticosteroids up to 60 milligrams daily of prednisone. And so when she was tapered to hydrocortisone replacement for her persistent adrenal insufficiency, she started to have musculoskeletal issues. And she started to have aching in her hips, her knees, and her shoulders that was most prominent after she received her nivolumab infusions. And she finished her immunotherapy with a great tumor response, a complete response of her tumor, but her joint symptoms persisted. And then she started noting swelling in her PIPs and MCPs and difficulty using her hands. And so she was referred to us in rheumatology about 6 months after her checkpoint inhibitor was stopped. And on physical exam, she had synovitis in multiple PIPs in her wrists and in both her knees. And so from her exam, she looked for all the world like she had rheumatoid arthritis. We checked some laboratory studies. Her rheumatoid factor, anti-CCP antibodies, and ANA were negative. And so she was started on a prednisone taper and methotrexate for her inflammatory arthritis. And she didn't tolerate the methotrexate ultimately, so we switched her to adalimumab with a good response initially. She lost response to adalimumab and was switched to etanercept. And she remains on etanercept for treatment of her inflammatory arthritis. And her melanoma remains in remission after greater than 24 months of TNF inhibitor therapy for her inflammatory arthritis. So this was a fairly dramatic case of checkpoint inhibitor-induced inflammatory arthritis. And it definitely captures one end of the spectrum of what we see in this disease. So there's a very heterogeneous presentation in different clinical aspects of inflammatory arthritis due to checkpoint inhibitors. For example, the time to development can differ greatly. Some patients may have symptoms after the first infusion to even after checkpoint inhibitor therapy is stopped having their first symptoms. So 1 week to greater than 2 years after starting checkpoint inhibitor therapy, patients may develop inflammatory arthritis. And this is seen across all tumor types. There's not a clear predilection for a particular underlying cancer. The severity ranges widely, but right now we have no comprehensive studies comparing the epidemiology of inflammatory arthritis by type of checkpoint inhibitor or by tumor type. So it's unclear how these affect how likely patients are to develop inflammatory arthritis. For most patients, however, they'll have medium to large joints affected first. In our cohort of patients, the knee is the most likely joint to be affected first in their course. Patients might also have ankles or shoulders involved initially. But over time, particularly if patients continue on their checkpoint inhibitor, they will undergo an additive course and they may evolve to have small joint involvement. And the number of joints involved can vary greatly. Monoarthritis is not very common, but oligoarthritis and polyarthritis are both seen commonly. We have seen reactive arthritis like phenotype with conjunctivitis and sterourethritis, but this is rare. Tenosynovitis and other tendon involvement, enthesitis can be seen. And axial disease has not been commonly appreciated, but a few cases have been reported. So really running the gamut of inflammatory arthritis phenotype. So when we evaluate patients and do initial testing, we see that for many patients, inflammatory markers are elevated. About 70% of patients in our cohort will have an elevated ESR or CRP when they're presenting with inflammatory arthritis due to checkpoint inhibitors. And initially, I wondered how useful checking inflammatory markers would be in patients who have active cancer and advanced cancer. And it turns out it can be quite useful, and it typically tracks with disease activity for those who have elevated inflammatory markers at the beginning. And I've learned that a lot of patients with advanced cancer have totally normal inflammatory markers. So even though that's always on our differential for elevated inflammatory markers, a malignancy driving it, a lot of patients are totally normal. HLA-B27 seems to be negative in a majority of patients. We check that in all of our patients and have not found many patients who are positive. When you look at autoantibodies, most patients, about 90%, are seronegative for rheumatoid factor and anti-CCP antibodies. Now, there have been cases of seropositive RA reported, in particular from France. And when they looked back in the patients where they had serum from before checkpoint inhibitor therapy, they saw that some of these patients already had the antibodies before they started checkpoint inhibitor therapy, but just did not have clinical disease. So that certainly is probably a subset of people who are at risk for RA and then are tipped over the edge by these immune checkpoint inhibitors. But for most patients, it seems to be a seronegative inflammatory arthritis. If you do a joint aspiration, you'll see an elevated white blood cell count, around 3 to 30,000 is typical, with a neutrophil predominance. And on imaging, we've seen a variety of findings that you would see in rheumatoid arthritis or in spondyloarthritis, including joint effusions, synovitis with Doppler signal, erosions, tenosynovitis, and enthesitis. And these are just a few ultrasound images captured by Dr. Albaida, who runs our ultrasound clinic at Johns Hopkins. So you see here talonavicular synovitis, that's Doppler positive with an erosion in the bone. Here we see 3+ Doppler signal with knee synovitis. In this panel, a bulky patellar enthesophyte. And then wrist tenosynovitis with fluid around the tendons and Doppler enhancement of the tendon sheath. So a wide range of imaging findings with ultrasound or other modalities. So how do we go about treating patients with inflammatory arthritis due to checkpoint inhibitors? For mild cases, we're often able to manage with NSAIDs or intra-articular steroids if there are only one or two joints involved. However, for most of the patients who end up seeing a rheumatologist, corticosteroids are needed. So that's been about 3/4 in our cohort of patients who needed systemic corticosteroids. DMARDs and biologics are often required, and we've used methotrexate, leflunomide, alpha-salazine, TNF inhibitors, tocilizumab, depending on the particular clinical scenario. And what has been really interesting to us in following these patients over time is noticing that many patients will have persistence of symptoms after the checkpoint inhibitor is stopped. And that is different from a lot of other IRAEs, such as colitis or dermatitis, which tend to be self-limited and resolve fairly quickly. So the effects of checkpoint inhibitors can persist for months after cessation, but the inflammatory arthritis can last even longer than that. And I think that's an important thing to remember. So when we tried to look at this a little bit more in depth, we had one of our postdoctoral fellows who's now on faculty at University of Utah, Tani Broughton, look into this question. And she found 60 patients where they had at least one follow-up after checkpoint inhibitor cessation. And when we looked going out from checkpoint inhibitor cessation, at 3 months, we had follow-up of 51 patients and 70% had active disease. And at 6 months, we had follow-up for 41 patients and nearly 49% had active disease 6 months after checkpoint inhibitor therapy was stopped. So it supported what we had noticed anecdotally, that for a lot of these patients, this was becoming a chronic issue. We wanted to understand if there were any particular risk factors that we could identify that would make people at more risk for having persistent arthritis. And so one thing we found was combination therapy. So patients that were treated with anti-CTLA-4 and anti-PD-1 therapy, which is in the red hashed line here, they were more likely to have persistent arthritis. So for these graphs, this is the y-axis is the proportion of patients with active inflammatory arthritis. So as that goes down, it means more people are resolving their arthritis. So the combination therapy group had a larger percentage of persistent patients. And the number of IRAEs also seemed to influence persistent arthritis. So the green hash line here is patients who had at least 2 other IRAEs in addition to their arthritis, and they also were more likely to have persistent arthritis. In addition, not shown here, a longer duration of checkpoint inhibitor therapy was independently associated with a higher risk for persistent arthritis. So still much more work to be done here with larger numbers of patients, but something to look out for in your practice, that patients may still have symptoms and need treatment long after their checkpoint inhibitor is stopped. So how does inflammatory arthritis from checkpoint inhibitors stack up to what we typically deal with as rheumatologists, rheumatoid arthritis and spondyloarthritis? Well, there are definitely similarities to both entities. You can have patients with polyarthritis, like the case we discussed, that looks very much like rheumatoid arthritis. They can develop erosions in a matter of months. They can have small joint involvement. But on the other hand, most are negative for rheumatoid factor or anti-CCP antibodies, and it's not a female predominant disease. With spondyloarthritis, some patients may have enthesitis, enthesophytes, and dactylitis, or even reactive arthritis, which can be similar. However, most patients are negative for HLA-B27. We're not seeing a lot of concomitant psoriasis, and we're not seeing a lot of inflammatory axial disease. So it does not fit nicely into our traditional categories of inflammatory arthritis, and I think needs to be treated as its own disease. So moving on from inflammatory arthritis to our next syndrome, Another case from the early days of seeing patients several years ago. This was a 61-year-old man with metastatic lung cancer who was started on nivolumab, an anti-PD-1 agent. And about a month and a half after he started therapy, he noticed that he had difficulty swallowing, very dry mouth, a sensation that his tongue was burning, and decreased ability to taste. So oncology gave him a course of fluconazole, which helped with the sensation of burning tongue, but did not help with his dry mouth. He did not have any dry eyes or foreign body sensation in the eye or parotid gland swelling. And on exam, he had very severe xerostomia, and labs showed a positive ANA, a slightly elevated rheumatoid factor, but he was negative for Rho and Law antibodies. And he was managed with topical oral agents initially, but then with cevimeline, with some improvement of his dry mouth. So this is a case of Sika syndrome occurring from checkpoint inhibitors. And it really can be significantly impactful to patients. So something that we, I think, as rheumatologists can really help our oncology colleagues with improving patients' quality of life. So patients may develop dry mouth and dry eyes, and the onset can be quite acute and severe, especially as compared to Sjogren's syndrome. The median time to develop Sika syndrome from checkpoint inhibitors was 70 days after starting checkpoint inhibitors in one series of patients. What's a little bit different from Sjogren's syndrome is that the dry mouth symptoms are more pronounced in pretty much all of the patients. So in a series of 20 patients, 14 had no ocular symptoms and 4 out of 5 in another. Parotitis has only been reported in one patient. There has also been a mucositis that is different from Sika syndrome from checkpoint inhibitors that I mentioned briefly here. So when you evaluate patients, if you do a whole unstimulated salivary flow, you'll find very decreased volumes. In patients with ocular symptoms and even some without, Schirmer's test may be positive. In the NIH cohort of 20 patients, 25% had a positive Schirmer's test. It was a little bit higher in a European cohort, a slightly larger European cohort, where 38% had a positive Schirmer's test. And like with inflammatory arthritis, the majority of patients are negative for Rho and Law antibodies. So some different percentages, but it looks like 80 to 90% of patients are seronegative. So when patient, I think some of the most interesting data here, and probably the most compelling that this is a different entity than primary Sjogren's syndrome, is minor salivary gland biopsy data. And there are some patients who have similar biopsies to Sjogren with focal lymphocytic sialadenitis, but there are also patients with a totally different pattern. So as we go through the panels here, I think it's actually useful to start on the bottom. And so this is an example of primary Sjogren's syndrome with a focus score of 6, so very high focus score. And you can see the foci of lymphocytes that are both CD4 positive and CD20 positive. So you've got T cells and B cells even more intense staining in these foci throughout the salivary gland. And then in the middle panel, you see checkpoint inhibitor-associated severe sialadenitis. And you see T cells, particularly CD4 positive, but some CD8 positive T cells that have really infiltrated the whole gland. And there's really an absence of B cells. And there's upregulation of PD-1 and PD-L1 on cells in the gland. And we don't have zoomed in views here, but there's really a destruction of architecture of the gland and injury to ducts and acini. So really, at a bird's eye view, it's clear that this is a different histological process than primary Sjogren's syndrome. So how do we treat Sika syndrome? We treat it much the same as we do in our other diseases, with starting with saliva substitutes, topical therapy, going on to sialagogues like cevimeline and pilocarpine if needed, encouraging dental care, ophthalmology care. For dry eyes, artificial tears, punctal plugs, close follow-up with ophthalmology. And what's a little bit different here is a recommendation for patients with severe symptoms for a prednisone taper. So prednisone 40 milligrams a day for patients who have grade 2 or higher symptoms. So these would be your patients who can't chew or swallow without copious fluids, who are restricting their diet to purees or soft, moist foods. Those patients may benefit from prednisone and actually may get some salivary function back. So as we stack up Sicca syndrome from checkpoint inhibitors compared to primary Sjogren's syndrome, there are some similarities. The dry mouth response to sialagogues. The dry mouth can be severe and associated with candida overgrowth. But there are key differences like the seronegativity, that the pathology is very different, that checkpoint inhibitor-induced disease typically has a better response to steroids, and in checkpoint inhibitor-induced disease, the dry mouth typically is much worse than the dry eyes. So moving on to another presentation. This is a 61-year-old woman with stage 3B poorly differentiated carcinoma who was on a clinical trial with durvalumab. And 1 month after starting, she developed pneumonitis, or inflammation of the lungs, and was on steroids for her pneumonitis and extended taper from May to September. After she stopped her steroids, however, she noticed new musculoskeletal symptoms, so sort of similar to our first patient. She had worsening pain in her shoulders, her hips, and buttocks, and she had a lot of morning stiffness in her hips and shoulders. She did not have any symptoms of temporal headache, scalp tenderness, jaw claudication, and there were no visual symptoms. And on examination, she had no synovitis, dactylitis, enthesitis, but she was tender over both her shoulders and her bilateral greater trochanteric areas. And on laboratory studies, her inflammatory markers were quite elevated, both CRP and ESR. And so in this setting, she was diagnosed with polymyalgia rheumatica. And she was started on 15 milligrams of prednisone daily with immediate improvement and tapered off once she started on chemotherapy for her cancer without recurrence of her PMR-like symptoms. So PMR and GCA have both been reported with checkpoint inhibitors, but PMR appears to be much more common than GCA in our experience. So patients with PMR may present with shoulder and hip girdle pain and stiffness, morning stiffness. Some groups have also described peripheral arthritis developing in patients who had initially predominant PMR symptoms, and how to classify that, whether that's more consistent with inflammatory arthritis or more consistent with PMR, is a little unclear. GCA, giant cell arteritis, patients may or may not have PMR-like symptoms, and all of the typical symptoms of temporal headache, jaw claudication, and vision loss have been reported. And both of these have been seen with CTLA-4 and PD-1 inhibition. So when you check inflammatory markers in patients with GCA from checkpoint inhibitors, they're very elevated, very high CRP levels. With PMR alone, most have elevated inflammatory markers, but there are some patients who have very PMR-like symptoms and not the elevated inflammatory markers that you typically see. So important to keep in mind for checkpoint inhibitor patients. If you do an ultrasound for PMR, you may see subdeltoid bursitis, biceps tenosynovitis, hip or trochanteric bursitis, all the things you typically see with PMR. Temporal artery biopsy is very critical in patients where GCA is expected because, as we all know, multiple headaches are steroid responsive, and it doesn't necessarily mean they have a vasculitis. And it really affects the future of their cancer treatment because patients with biopsy-proven GCA are unlikely to be retrialed with checkpoint inhibitor therapy. And corticosteroids are the mainstay of management. GCA, prednisone, 40 milligrams or higher, pulse dose steroids with IV salumedrol if the patient's vision is threatened. And for PMR, the range of prednisone is a little bit larger than you typically see with traditional PMR, and some patients may need much higher doses of steroids to get relief, up to 60 milligrams a day. And for refractory patients, tocilizumab use has been described. So comparing these to traditional rheumatic diseases with PMR, or as the oncologists like to call it, polymyalgia-like syndrome. We see similar ultrasound findings as with PMR not associated with checkpoint inhibitors, but the inflammatory markers are not always increased, and they may have higher prednisone requirements than our traditional PMR patients. And with giant cell arteritis, the temporal artery biopsy findings have been identical to patients with giant cell arteritis not associated with checkpoint inhibitors. The age has been greater than 50 in all of the reported cases in the literature, and patients tend to have very high inflammatory markers. But the associated aortitis and other large vessel vasculitis has not yet been reported for giant cell arteritis associated with checkpoint inhibitors. And that's not clear if it's because people aren't looking for it, or if it's not actually part of the syndrome. So I think as more cases are identified, we'll understand that better. So moving on to our last clinical scenario, this is a 61-year-old woman with ovarian cancer who developed symptoms 1 month after starting immunotherapy with an anti-PD-L1 agent. She had proximal muscle weakness, was having difficulty rising from seated and doing her hair. She had no rash or other new symptoms. And when labs were checked, her creatinine kinase was elevated at 1400, and her ANA was positive. Her checkpoint inhibitor was stopped by oncology, and she was started on prednisone at 1 mg per kg. Myositis-specific and associated antibodies were negative. And she got referred to rheumatology about a month after being on prednisone by oncology. At that point, her MRI showed muscle atrophy with mild to moderate fatty replacement in her thigh, so suggestive of prior myositis, but not active myositis on prednisone. And her EMG was actually normal after a month of prednisone. But with treatment of prednisone and holding the checkpoint inhibitor, she had a normalization of both her CK and strength, and she was not re-challenged with a checkpoint inhibitor after that. And so this would have been a polymyositis-like presentation due to checkpoint inhibitors. And so polymyositis, like myositis, is much more common than dermatomyositis when associated with checkpoint inhibitors. And patients will have proximal muscle weakness pretty much across the board. There is some distal weakness also reported. And important to note that diaphragmatic weakness and dysphagia associated with myositis can be seen. And they also can be overlapped with either myasthenia gravis or myocarditis. So this is really a key not to miss patient. And the recommendation is that if a patient has either myositis, myasthenia, or myocarditis from checkpoint inhibitors, they should be evaluated for the other two conditions because they can occur together. And potentially it's a life-threatening scenario. Now, dermatomyositis has been described, but much more rarely, with the classic rash on sun-exposed areas, Gottron's papules, and typical nail-fold capillary abnormalities, along with proximal muscle weakness. But most patients won't have the typical rash when associated with checkpoint inhibitors. The range of CK and the published cases ranges from 1,000 to 10,000 units per liter. There are also reports of transient high CK with minimal symptoms, with minimal weakness or myalgia. So that's an important thing to keep in mind. And a lot of patients on clinical trials may have their CK checked regularly, just as a part of clinical trial labs. And so they may see this. And those patients, if their CK trends down and they've never had any symptoms, are probably safe to continue on checkpoint inhibitor therapy. If you do an EMG, you'll see an irritable myopathy. MRI has shown muscle and fascial inflammation, so it can be useful. And in patients where there have been muscle biopsies, there's been endomysial lymphocytic infiltrate that's seen, and also muscle biopsies that look similar to immune-mediated necrotizing myopathy. And here are just a few MRIs from a patient who had both ocular myositis along with peripheral myositis, and you can see the increase hyperintense signal on the stir sequence brachial muscle and femoral muscle in this particular patient. So as with other IRAEs, corticosteroids are the initial treatment, both IV and oral reported, wide range, pulse dose, 1,000 milligrams of methylprednisolone in patients who have any diaphragmatic involvement or dysphagia going on. IVIG is typically what will be tried next if corticosteroids are non-effective or plasma exchange. And for all patients who have symptomatic myositis, the checkpoint inhibitors are held or stopped. And for most patients with severe symptoms, they won't be re-challenged again. So the rheumatic IRE of myositis does have some similarities to dermatomyositis, polymyositis, and immune-mediated necrotizing myopathy. The CK levels are typically similar, as are EMG findings and MRI findings with muscle and fascial inflammation. The muscle biopsy can look like polymyositis or immune-mediated necrotizing myopathy, but classic dermatomyositis rashes are rare. Not clear, but IVIG may be less effective in checkpoint inhibitor-associated myositis. Like with the other syndromes we've talked about, myositis, autoantibodies are not typically seen in checkpoint inhibitor-induced disease. And important to remember that myocarditis and myasthenia overlap are more common with checkpoint inhibitor-induced disease. So for all of these patients, we talked about steroids and other forms of immunosuppression, and there's a natural concern that suppressing people's immune system with advanced cancer, where you've wanted to activate their immune system against the cancer, would be a negative thing for tumor response. And I think it's a more nuanced answer than, immunosuppression is strictly bad, which is what we thought at the beginning. And the data is mixed on the subject, and the amount of immunosuppression and the timing of immunosuppression is probably important. So if you look at melanoma, where checkpoint inhibitors were used first, and we have the largest data sets, corticosteroids or short-term TNF inhibitors for any IRE did not affect melanoma response, either to ipilimumab or to nivolumab. So reassuring data with hundreds of melanoma patients. And then there have been similar studies done pooling data of patients with multiple tumors on anti-PD-1, showing that IRAEs requiring steroids did not negatively influence survival or tumor response. So some reassuring data that, when you need to treat the IRAE, you can without affecting tumor response. There is one study, though, that gives us some concern, which is looking at hepatocytis due to ipilimumab in melanoma patients. And in that study, they showed that patients who got high-dose steroids versus just hydrocortisone for adrenal replacement had worse survival. So it does give us some pause when we think about immunosuppression. And in another study with non-small cell lung cancer, baseline corticosteroids, which was mostly for reactive airway disease, greater than 10 milligrams, was associated with worse tumor response. So I think the amount of immunosuppression and the timing are likely important, but the general consensus is that if you need to treat the IRAEs, you treat them and get them under control as quickly as you can. In our own cohort, we were curious to look at this question in our inflammatory arthritis patients, and we compared those who received CSC, MARDs, and biologics to those who did not, and we did not see a difference in tumor progression. So in our last 6 minutes or so, just briefly touch on our patients with pre-existing autoimmunity and cancer who need checkpoint inhibitors. And this has been a difficult group to deal with because our patients were excluded from the initial trials of immune checkpoint inhibitors for their pre-existing autoimmune disease. So there's limited data here, although many patients now have been treated as a standard of care. And so we have data from several retrospective series, a few systematic reviews, and one national study out of France that I'll review briefly. So in a systematic review from 2018 from MD Anderson, they looked at case reports and series of patients with autoimmune disease and cancer who were treated with checkpoint inhibitors. And they had 123 patients with a wide variety of autoimmune disease. Psoriasis and psoriatic arthritis were the most common, followed by RA and thyroid disease, inflammatory bowel disease. And of these patients, about 75% had an exacerbation of their pre-existing autoimmune disease. And they didn't see a difference when comparing those who had active or inactive autoimmune disease at the start. Now, I caution you on this number of 75% because they included case reports, and it's unlikely that a case report is written when everything went beautifully and they didn't have an exacerbation. So that's just important to remember when you're thinking about the numbers. 25% of patients had a de novo IRAE, and only 17% needed to discontinue therapy either due to a flare of their autoimmune disease or a de novo IRAE. So the vast majority of patients, even if they had a flare, could tolerate being treated with checkpoint inhibitors. And some other data from that study, one that I think was interesting is that those treated with anti-PD-1 or PD-L1 had a higher rate of flare or exacerbation of their autoimmune disease, but those treated with ipilimumab had a higher rate of de novo IRAE. And we know that to be true, that ipilimumab, the rates of IRAEs are higher than the PD-1, PD-L1 agents. In their RA patients, 60% of patients had either a flare or a de novo IRAE, 35% only a flare, 25% only an IRAE, and 15% both. So at ACR last year, there were several other studies on pre-existing autoimmune disease, and flares in one study in 29%, in an RA study, flares in 55%, and in a Canadian study, 50% of patients with RA with flare. So I think 50% or a little bit less is probably where the numbers will settle out in terms of how many patients have a flare. And then I mentioned this final study, which was a national study from France that was published in ANR in 2019, looking at patients with autoimmune disease, some of which were on DMARDs or steroids at checkpoint inhibitor start, and some of which were not. They saw flares in 53% of patients, again, around the same numbers. But what was really notable about the study is that the median progression-free survival was shorter in patients on immunosuppression, so 3.8 months versus 12 months for patients not on immunosuppression. And the graphs are here for progression-free survival on the left and overall survival on the right. And the immunosuppressed patients are the dotted line in both of these graphs. So again, this was at the start of checkpoint inhibitor therapy. So another piece of information that the timing of immunosuppression may be important. And it's something we really have to think about carefully in managing our patients with rheumatic disease as they start checkpoint inhibitor therapy. So there are many unanswered questions in this field. I encourage you, if you want an area to really sink your teeth into research-wise or clinically, that this is a great area of immense growth. We need to understand the underlying pathophysiology of rheumatic IRAEs. Why do they occur? How are they similar? And how are they different from traditional autoimmune disease? We need to understand risk stratification, who's likely to develop an IRAE and who is less likely. The effects of long-term IRA treatment on tumor response and long-term outcomes are very important to understand so we can maximally treat our patients. And we have a question of whether persistence of IRAEs is a good biomarker for tumor response. How do we manage and monitor our patients with pre-existing autoimmune disease who start checkpoint inhibitors? And that's just a very brief list of what are an ever-growing list of questions as we take care of these patients and try to understand how to manage them in the best way and for the best cancer outcomes, in addition to the best outcomes for their IRAEs or rheumatic disease. So I just want to acknowledge my many mentors, collaborators, mentees in rheumatology, do this kind of work. And I think I'm exactly at 10:50. So we can stop and answer any questions you have. Thank you.
Terrific, Laura. That was very informative and very much like the current pandemic. This is unfolding and we're learning more by just observation. We have a number of questions and I'll ask Jean, our co-moderator. Oh, sorry about that. I need to start the video. Our co-moderator to begin those questions.
Okay, thank you. Thank you for such an informative talk, Dr. Cappelli. A lot of the questions started out with, I think because there have been publications of concerns with TNF inhibitors with malignancy, a lot of people have asked, when do you feel safe using TNF inhibitors? When do you choose another? And then how do you counsel patients?
Yeah, that is a great question. And that is typically the first question that I get asked when I talk in person also. So good first question here. So I think there's a couple of things. One, in terms of counseling patients generally about TNF inhibitors and risk of new cancers, I think we have a lot of reassuring data out of Europe from large registries that there is not an increased signal for solid malignancies, melanoma, or lymphoma. So I think time and using these drugs has given us more understanding that at least in rheumatic disease compared to rheumatic disease controls, these drugs are not associated with an increased risk of de novo malignancy. Now that's a different question for then patients who have concomitant cancer and we're trying to treat their cancer. So I cite the data that I cited in this talk about melanoma, that we feel confident that short-term TNF inhibition does not affect tumor outcomes. We know less about long-term TNF inhibition. But I think the TNF story is about to get a lot more interesting because there are actually trials looking at TNF inhibitors with checkpoint inhibitors at the same time to improve tumor response. So the effects of TNF are complicated, and there is some animal data, early clinical data, that it actually may be beneficial to be giving people TNF inhibitors with checkpoint inhibitors. So those trials are ongoing on clinicaltrials.gov. So I think it's a very nuanced conversation with patients, which can be difficult to have and it can be very time consuming, but you sort of need to take in data from many different sources and put it together and then try to present it in a way a patient can understand and so the patient knows the limitations of our knowledge. But basically when I'm making a choice, TNF inhibitors, unless the patient has a contraindication, are usually the first biologics that we use because there's the most experience with them in IRAEs.
Thank you.
Thank you. There have been some questions, Laura, on whether individuals that are having aggressive responses to checkpoint inhibitors, and i.e. aggressive checkpoint inhibitor related events, immune related events, do they tend to have better tumor responses? So they're developing severe inflammatory arthritis. We think that the checkpoint inhibitor might be working better.
Yes, there is good data for that in several tumor types. So there's data for that in melanoma, in non-small cell lung cancer, and in renal cell, that patients who develop higher grade IRAEs, if they survive their grade 3 or higher IRAE, do have better tumor responses. So that does seem to be linked. And in our experience also, and I didn't show this, having those patients who have persistent arthritis, there has been a trend to having better tumor outcomes. So there is, I think, something to be said for a robust immune response that's leading to non-target tissue, non-tumor tissue damage, also potentially being a biomarker for a good tumor response.
And we think that's independent of DMARD addition.
So, that I think we need a lot more patients to really study that in detail, because right now we're sort of limited. It's really only in melanoma that they have large enough patient sets to look at this comprehensively. So I think we will stay tuned for that one. But so far, it seems that you don't take away the effect when you give immunosuppression, minus that one study of hypophysitis where you do. So conflicting data, and we just need larger data sets and more analysis.
I think going along the lines of that question a little bit, there's been a lot of questions about discussing more about the treatment. Like, when do you continue to co-treat? Are there times when you ask the oncologist or maybe the oncologist decides to stop the immune checkpoint inhibitors? And then I guess even when do you decide that this is a flare, it needs steroids versus it needs like a TNF?
Yeah, I mean, it definitely is. It's definitely patient dependent and where they are in their treatment. So we do co-treat if the oncologist feels that they need to remain on the checkpoint inhibitor. We co-treat patients. We co-treat them with prednisone 10 milligrams daily. We've co-treated them with methotrexate, with leflunomide while they've been giving the checkpoint inhibitor. We haven't typically, if patients are severe enough to need a biologic, we typically haven't been treating them at the same time they've been getting the checkpoint inhibitor, but they have been in GI. So they have been for colitis patients. Or some of our colleagues at Mass General and other places have published on co-administering TNF inhibitors with the checkpoint inhibitors. And that's also been published with tocilizumab for arthritis in a few cases. So I think every patient, it's a discussion with the oncologist with what's your ideal plan with the checkpoint inhibitor? Like, what is the duration you're going for? What is the patient's current response? How likely they are to respond? And then we try to fit our treatment into that plan, because what's different about treating these patients than any of our other patients is that their rheumatic syndrome is not their main concern. Their main concern is their cancer. So we have to be respectful of that and sort of fit in. In terms of when do I pull the trigger on a TNF or other biologic versus, doing a conventional synthetic DMARD, I think it depends on both severity and how quickly I want the agent to work. So if we're just on a break from checkpoint inhibitors and they want to go back on, I may give a course of TNF before methotrexate just to try to get the disease under control and then go back on. If patients are done with their checkpoint inhibitors and they're not severely limited by their arthritis, then I think conventional synthetic DMARDs make the most sense. And that's what we typically do as a steroid-sparing agent, methotrexate or leflunomide or sulfasalazine, depending on the scenario.
There was a practical question on how you can get some of the biologics approved for immune checkpoint-related events.
We do. So we code patients as seronegative RA.
Okay.
Typically. Because they meet criteria technically, and that's what we have been typically doing, as this reported. But I think so. There's that. I think a lot of companies are willing to help with patient assistance in this scenario. So we have not had too much trouble with that.
Have you seen safety warnings faxed over saying your patient's a history of melanoma and being treated with a TNF?
I mean, yeah, I guess we probably get some of those, but I think we sort of have a more nuanced view of the data. And we have there's a long history in melanoma of using TNF inhibitors to treat colitis from ipilimumab. So our melanoma doctors are actually totally comfortable with TNF inhibitors since they've been treating patients with immune checkpoint inhibitors since the beginning. So they're probably more comfortable than, even most rheumatologists in giving patients with melanoma TNF inhibitors.
Great. We've also had a couple questions about how do you tease out the immune adverse events from checkpoint inhibitors versus like a more paraneoplastic syndrome. So for instance, like PMR can be associated with cancer, or like myositis. Is there a way to tease that out? Because theoretically, if it's cancer related, you treat the cancer, but if it's autoimmune related, you give them steroids or it changes treatment.
Yeah, I think it's all about timing and your clinical impression. And I think sometimes you're unable to totally tease it out in the setting of dermatomyositis. But for most of these patients who are able to give a reasonable history, if they really had no symptoms, they had the cancer before, and presumably for a long time, at least at a microscopic level, they've had the cancer before they're actually on checkpoint inhibitors. And if they're only now having symptoms, I think it's for the most part fair to say that it's related to the checkpoint inhibitors. So from a practical standpoint, I don't know that that's been a huge issue.
With that, I'd like to thank Dr. Cappelli for this very relevant and interesting lecture. I would like to add that thus far there's been over 1,900 registrants for the virtual rheumatology learning, and it's touched over 50 countries. On an average, there are about 450 attendees for each of the virtual lectures, so this is reaching really globally. Thank you, Laura. Questions will be sent to Dr. Cappelli, and they will be forwarded to the group. Thanks so much. Take care and be safe, all. Bye-bye.
Bye-bye.